Hello student, I hope everything is audible and visible at your end. So this is Dr. Soumen Manna, your physiology teacher. Good evening to all of you. Yes, I think everything is perfect at your end, audio and video, right. Good evening to all of you. I am not taking names, but I can find out many are joining. Very good. Right, thank you so much. So without wasting much of the time, let's start the session. Right, perfect. Okay. Chalo. So we are going to discuss the important images of physiology. So this is an image based question session. I will discuss few images which has already been asked in the MCQs or they may be asked in future, right. But before starting the session, first of all I will give you a glimpse that what are the important topics you should concentrate in physiology, because you know I know that this is a crucial time. You don't have much time, you have to revise many subjects, all the 19 subjects you have to revise. So in between that 19 subject, revision for physiology is a very important part, but you cannot devote much of the time for physiology, I know, right. So what are the important topics that you should concentrate for physiology? So these are the first thing, right. So general physiology, I have written some topic, okay. So these are most important topic in general physio for upcoming NEET entrance examinations. You have to revise at least this topic. Similarly, the nerve muscle physio, see I have written only few topics in nerve muscle physiology. So at least please revise this topic before going into examinations. Similarly, in central nervous system, EPSP, that is the excitatory postsynaptic potential, right, inhibitory postsynaptic potential, motor end potential and Rensa cell inhibition are very important topic. And all of you know the muscle spindle and Golgi tendon apparatus along with the tactile receptor and the adaptation phenomenon of the receptor, all these things you have to read. And in hypothalamus, particularly the nuclei of the hypothalamus and their functions, these are the important topic. Similarly, in GIT at least you read migratory motor complex and basal electrical rhythm, right. And for CVS, see very less number of topic I have noted here. At least you read JVP, preload, afterload and PV loop, okay. So these are the important area from where the questions has been asked, not only NEET for INI-CET examination also. Similarly, you have to read about the baroreceptor, Cushing reflex, Bain-Bridge reflex and Bajol-Jeris reflex, okay. And in renal physiology, the list of topics are here. In respiratory, the list you can find out here. And in endocrine, only the hormone receptor is the most important thing that you have to revise before going into examination, right. So I think right, so I think they will check and the volume will be increased soon, but otherwise video and audio is ठीक है ना आपके पास, right, okay. PDF of this, okay, obviously it will be provided, don't worry. So now after discussing these important topics, we are entering into the direct discussion of the MCQs. So I will give you a MCQ first, you will look at and try to answer as faster as possible, because you know there is a time lag and we have only 2 hour session, right. So first MCQ is coming in front of you. This is a repeat MCQ in NEET entrance examinations. I think all of you know the answer of this. So here you can find out that 2 cells has been shown and in one of the cell is secreting certain product and that product is working or acting on the nearby cell, adjacent cell. So obviously this kind of signaling is known as paracrine type of signaling, okay. All of you are giving good answer, right, and obviously this is the correct answer, paracrine signaling. So what we have to read in this topic, we have to read that there are 4 types of signaling I have to remember. One is endocrine, one is autocrine, you know this, and one is paracrine and one is juxtacrine. So basically if you look at this endocrine and autocrine signaling, from the name you can easily make out what is the meaning of this signaling. See, endocrine signaling means if the gland is here, the gland is secreting some product, the product will travel through blood and it will work on a distant organ. So it is traveling through blood. That is the most important thing in endocrine type of signaling, right? In autocrine, you can easily understand auto means it is acting on the same cell, right? So the product is secreted from the cell and it is acting on the same cell onto the receptor. The typical example of this autocrine type of signaling is PAF, okay? So platelet activating factor, this is one of the important autocrine signaling example that you have to remember. Now look at these two important things. One is paracrine and one is juxtacrine, okay? According to the meaning, both are almost same, but there is a little difference between these two. Paracrine means when a cell is secreting some product and the product is going to the nearby cell by the process of diffusion, right? Two cells are located near to each other. Cells secretion from one cell is acting on the nearby cell by the process of diffusion. So it has to travel, the product has to travel, but not through blood, by the process of diffusion only. But in case of juxtacrine, the cells are too close with one another. So the two cells, they are so close with one another that the ligand from one cells is directly interacting with the receptor on other cells. Getting my point? So here the cells are in close contact. So juxtacrine means the cells should be in very close contact, so that the surface receptor from one cell is interacting with the ligand from other cells. The typical example of this kind of thing is that the transforming growth factor beta and alpha, right? So transforming growth factor alpha is one of the important examples of this juxtacrine type of signaling. Now paracrine signaling examples, many examples are there. All of you know that somatostatin, if you think of somatostatin at the level of stomach. So somatostatin by the process of diffusion goes towards the parietal cells and it inhibits the secretion from the parietal cells. So that is a typical example of paracrine signaling. This much is important in this question. I am going to the next question. So next question is here, okay? Look at the questions and try to answer. Right. So I am waiting for answer. The question stem of the question is a little lengthier, but I think this is okay. Okay. So three different types of transporter has been given in this question. One is X, one is Y, and one is Z, right? And the question is saying that the cells contain the concentration of the ion which is similar to the mammalian cell concentration, means you have not changed the composition of the cell, intracellular and extracellular, means sodium concentration, calcium concentration, everything is same like that of the normal mammalian cell. Yes. So as you can find out here, the first, the transporter X, it is throwing sodium out of the cell and taking back potassium inside the cell. So this is typically the sodium potassium ATPase pump, sodium potassium ATPase pump, right? Getting my point? So sodium potassium ATPase pump, this is a primary active transporter, but this is not your question. The question is regarding Y. So Y here is throwing calcium out of the cell. This is against the concentration gradient and taking in the sodium along the concentration gradient. So this is an typically the antiporter system, right? So all symporter and antiporter, they are which type of transporter? Secondary active transporter. So please note down that this Y transporter is nothing but the secondary active transporter, because all the symporter and antiporter, they are secondary active transporter. If the molecule name is attached with ATPase, remember, if the molecule name is attached with ATPase, suppose hydrogen potassium ATPase, hydrogen ATPase, all of them are primary active transporter. Right. Now looking at these two, facilitated diffusion and simple diffusion, all of you know that diffusion is a passive process. It will occur from high concentration to the low solute concentration. But if the diffusion is occurring with the help of a carrier protein, then that type of diffusion is known as facilitated diffusion. What I told? Facilitated diffusion means it's a passive process, but you require the help of what? You require the help of carrier protein, right? You require the help of carrier protein. But whenever you look at this Z here, Z, what is Z? What do you think? If I ask rather than Y, what is Z, then what will be your answer within this A, B, C, D? Yes, what will be Z? Is a Z is a carrier protein? No, Z is not a carrier protein. What I can find out here? Yeah, very good, very good. So what I can find out here, the Z contain a lumen. Through this lumen, or you can say there is a pore, through this pore one molecule can goes in bidirectional manner, right? So this is typically of a channel. This is typically of a channel, and you know channels are nothing but they are simple channel ke through if the something is moving through channel, that is a simple diffusion process, right? So look at here, if you don't believe me, then you look at here, this is the diagram I have taken from Guyton. So here you can find out that this is channel protein. Channel proteins are put into the category of simple diffusion, right? So basically you have to understand that there is a difference between carrier protein, right? There is a difference between carrier protein and the channel protein, right? So in case of channel protein, there will be an internal pore inside the protein, and through this internal pore the molecule can move without any actual binding with the protein. But if you look at the carrier protein, see here, if you look at the carrier protein, suppose it is transporting sodium and potassium, or suppose it is transporting sodium and calcium. So first the sodium will binds, right? Then the carrier protein will change its shape, right? Then after just changing in shape, the sodium or the calcium which is attached with it, it will be released on the other side. Getting my point? Suppose this is calcium. Same way, if it is transporting sodium, first the sodium has to attach with this carrier protein, and then the carrier protein will change its shape, and after changing the shape, it will release the sodium from other side. Getting my point? So the bottom line is that carrier protein means it is actually binding with the substances which has to be transported, and then it is changing its shape, and then it is releasing the molecule. But in case of channel protein, neither it is changing its shape, neither it is actually binding with the substances which has to be transported. So all channel protein mediated transport, they are simple diffusion process. Simple diffusion can also occur without channel protein also, because you know if the substances is lipophilic substances like oxygen, carbon dioxide gases here, they can easily move without any channel, without any carrier protein. That is also a simple diffusion. So basically whenever a carrier protein mediated transport is occurring, it can be energy dependent also, it can be without energy also, non-energy dependent transport also. So carrier protein can be involved in energy dependent process also and non-energy dependent process also. If it is energy dependent process, then it is an active, and if it is non-energy dependent process, obviously this is an passive, but this passive is nothing but the facilitated diffusion. We say that all the glutes are facilitated diffusion, but all the symporter and antiporter, like for example if I say SGLT, these are the secondary active transporter. Okay? At least you remember this much of information for this kind of question. This is a diagram which has been given in Guyton. So you can find out here the carrier protein is responsible for facilitated diffusion also, as well as active transport process also. Am I clear? Right? So we are moving on to the next question. So the next question is a repeat questions of NEET 2022 examinations. Try to answer the question. So here whenever you get any graph in your exam, okay, physio में image based question means most of the questions will be graphs, okay. So whenever you are looking at any graph in physiology, what you are going to look at, first you look at x-axis, and then you look at y-axis, and then you try to understand. Don't look at what is happening inside the graph, because here you can find out one broken line, blue color line, one red color line. Whenever you are seeing this kind of images first time in your exam, you will get confused. Oh my God, I have not seen this kind of image in my life. One is broken line, one is red line. So don't do like that. First you look at x-axis, look at y-axis. So y-axis here is the body temperature. So if I follow the blue color line is saying to me that body temperature is rising suddenly. And if I look at the red color line on the first half, it indicating the body temperature is rising but slowly. This is the meaning of this two graph. If I have to explain for the first time, okay, suppose I don't know anything about this graph. So what I will understand from this blue color line, it is indicating that, yes, blue line indicating that the temperature is suddenly rising to a higher value, and red line indicating that the temperature is rising to a slow manner. Okay, so let's look at how it happens. So all of you know that hypothalamus is the main center which is responsible for thermoregulation, right? So I am writing here hypothalamus. Okay, it contains various nucleus. One of such nucleus control our thermoregulation process. Now, hypothalamus has a set point. What do you mean by set point? Set point means hypothalamus will say that the body temperature will remain at this temperature. Now, that is known as the set point. Set point can increase, decrease depending on the environmental temperature or depending on different parameter. But set point means hypothalamus is setting a temperature as a particular value. So, when the body temperature is normal, all of you know the body temperature is in and around 98.8 degree Fahrenheit. Okay. Suppose hypothalamus has already set the body temperature to 98.8. What will happen in this condition? The whole body will remain at the same temperature, that is 98.8 degree Fahrenheit. Okay. Now, suppose due to release of various pyrogens, you know pyrogens, है ना? Obviously you know. So, pyrogens are the substances which can causes fever, like for example interleukin-1 is one of the important pyrogens. So, whenever these pyrogens are released, right, what will happen? These pyrogens will act on the hypothalamus and it will suddenly rise the set point of hypothalamus. Suppose now the set point is set at 103 degree Fahrenheit. So, who is rising the set point? Who is changing the set point? Here the pyrogens. It can be changed in other means also, but here the pyrogens is rising the set point of the hypothalamus. But look at your body temperature is still at 98.8 degree. So, pyrogens has suddenly rise the set point, but your body temperature is still at 98.8. Now, what the body tissue will try to do? Body tissue will also try to rise its temperature to match with the set point, means body temperature will also rise and it will try to match with 103 degree Fahrenheit. But how to increase the body temperature? Body temperature increment cannot be sudden. It is a slow process. Why slow process? Now you either have to increase heat production into your body. So, either you have to increase heat production into your body or you have to decrease the heat loss from the body. So, that is why whenever your set point is suddenly rise to a higher value at the level of hypothalamus, body tissue will try to generate more and more heat and it will try to prevent heat loss as much as possible. So, what is going to happen? How can you do that? You know that all the mechanisms which happens in your body when you expose to cold environment, like your curling of the body, okay, shivering of the body, okay, piloerection of the body, all these things will happen and that will generate heat slowly, and whenever the heat production is sufficient, it will match with the hypothalamic set point temperature. That is why if you look at this curve, okay, the A indicating that the body tissue is gradually generating heat to match with the set point change. So, this blue color point already given in the question, this is the set point temperature has been raised and now the body is trying to reach to the set point by producing more and more heat production. So, now you look at, even if you do not understand the other part, I will come to that, but even if you do not look at the other part, what will be your answer? Which of the following, A, B, C, D may say, which of the following is a, okay, is a heat production mechanism, right? So, obviously answer क्या होगा? Obviously answer क्या होगा? Yes, A, B, C, D. Sweating होगा तो there will be heat loss, increase blood flow to the skin, that will also causes heat loss. So, only thing that is possible here is the shivering. So, that is why my answer here is shivering, right? Then what will happen? You know that this is the thing which is happening when the fever is coming, right? Now, what happens when the pyrogens are not there in the body? Hypothalamus again will decrease the set point, okay? Now, suppose अभी pyrogens आपका body में नहीं है, body से wash out हो गया. So, suddenly जो set point 103 में था, now this set point again come back to 98.8 degree Fahrenheit, normal temperature में वापिस आ जाएगा. But your body tissue already it is at 103 degree Fahrenheit, but set point has suddenly decreased to 98.8 again. Your body temperature is 103 degree Fahrenheit. So, what the body tissue will try to do to match the set point? Now, the body tissue has to lose the heat from the body. So, that is why there will be loss of heat from the body, okay? And whenever you want to lose your heat from the body, yes, there will be sweating, there will be vasodilatation. So, there will be vasodilation, the skin blood flow will be increased, your skin will looks like warm, okay? There will be huge amount of profuse amount of sweating, okay? So, whenever this kind of thing is happening, as a doctor, you know, now the fever is subsiding, right? So this is the part, first part, there will be chill, okay, chill and rigor, and this is the second part, when the fever is finishing, that time there will be flush reaction, जिसको हम लोग बोलते हैं crisis reaction भी बोलते हैं. So flush or crisis, right? So you know कि whenever your fever is coming for the first time, this is the first thing which is happening, and when you fever is subsiding from the body, the second thing is happening, that is the flush or crisis. Your body vasodilation will be there, your body will be profusely sweat. So that's why you look at this is the exact graph which is taken from Guyton, and this has been put into the question. So on the first half side, this is the A in your MCQ, okay. What is happening? There is chills, right? So the body is trying to generating heat, vasoconstriction, piloerection, epinephrine secretion and shivering, right? And when the crisis reaction is happening, the body is try to lose heat by vasodilation and sweating. समझ में आया? So this is the thing that you have to remember. Okay, समझ में आ गया? Okay. So I think अभी तक जितना डिस्कशन हुआ थोड़ा बहुत तो समझ में आ रहा है. Okay. So थोड़ा सा एक ब्रेक ले लेते हैं for giving a rest to your eye for a few seconds. So as you know कि PrepLadder is ready for next preparation, right? And all of you know that next is round the corner. So our team has is already prepared the question banks as well as the video lecture, and there is an elite plan for next entrance examinations, right? In this elite plan, you know ki what you are going to get, you are going to get all the video lectures, the updated video lecture of all 19 subject. Not only the video lecture, there will be question banks which are completely next type of question bank which contains 70% of the clinical based question. Along with that, you know, there will be next edition test series also there, as well as there will be the rapid revision course in this plan. So if you are opting for this plan, that is the elite plan for next entrance examinations, so you can book here from 21st January. Okay. So this is a short break. Now again the next question. So now we look at this question. Okay. So looking at this question, it's a detailed question, but read the question first and try to answer. क्या आंसर होना चाहिए? Okay. So there is a depolarization. Okay. Depolarization means this is an action potential. After the action potential, muscle is contracting and relaxing. Okay, all of you are thinking. If you look at the options, na, this question is easy. But apart from options, I want to understand that what is the meaning of this graph, right? So first of all of you look at. So the first, this green color curve, this is the depolarization. Depolarization means suppose you are generating one action potential on the muscle membrane. What will happen? The muscle will contract and relax. So this blue color and red color curve both are indicating that there is a contraction. So the contraction is going on here, and followed by, after the end of contraction, there will be a relaxation. This is the relaxation part. So this is the relaxation part, and this upper part is the contraction part. Okay, hold on. Okay, I will tell you the answer. So A and B both are muscle contraction and relaxation. समझ में आ रहा है? Okay, look at. To understand this thing, suppose this is my muscle. Suppose this is my muscle, skeletal muscle, and this is the neuron. Okay, this is the neuron which is connected to the muscle. If I stimulate the neuron, now don't try to answer, look at the explanation, very important question. So if I give a stimulus here, there will be action potential on this neuron, then that action potential will travel down the neuron, and the action potential will cross the neuromuscular junction. Then after crossing the neuromuscular junction, the muscle's membrane will produce another action potential, and that action potential will causes contraction of the muscle. Obviously after contraction there will be relaxation of the muscles. If I record this contraction and relaxation of the muscle, then in graphically how it will looks like, it will looks like that there is a phase of contraction where the tension, where the force generated by the muscle is rising. So, this pink color curve is the tension generated by the muscle or the force generated by the muscle, that is the phase of contraction, and then there will be a phase of relaxation. There will be a phase of relaxation where tension is decreasing. So, this is phase of contraction, this is phase of relaxation. So, I have generated a action potential at this point, but I can find out that there is a time gap between this action potential and the onset of contraction. This time gap between the action potential and the onset of contraction is known as the latent period of contraction, and the contraction and relaxation, this contraction and relaxation of the muscles as a whole, this is known as simple muscle twitch, simple muscle TWITCH, simple muscle twitch, और कभी कभी हम लोग twitch भी बोलते हैं. So, this is known as SMT. We say this is SMT, simple muscle twitch, means muscle will contract and then relax. Only one contraction, relaxation, simple muscle twitch. Getting my point? So, these A and B, if I ask you what are these? These are muscle contraction, relaxation, or you can say they are the twitch of the muscle. They are the muscle twitch, simple muscle twitch. Now, skeletal muscle are of two types. Do you know what are the types of skeletal muscle? There are something called red muscles and there is something called white muscles. All of you know that. But if I ask you, red muscles are which type? Type 1 or type 2? Anybody? Red muscles and white muscles. Skeletal muscle are of two types, red and white. Red is which type? Type 1 or type 2? Type 2 का भी A, B होता है. Detail I am not going to discuss here because time is less. But tell me, red one is type 1 or type 2? Red one is type 1 muscle and white is the type 2 muscle. Now, which one is slow twitch muscle? If I ask you type 1 or type 2, which one is the slow twitch muscle? Yes, which one is the slow twitch muscle? Exactly, very good, the new era in physics. Okay, so this type 1 is known as the slow twitch muscle. Okay, so this is known as the slow muscles, but its metabolism is oxidative type of metabolism and it's a fatigue resistance muscle, right? And this type 2 is the fast twitch muscle, fast twitch muscles. So, although it is fast twitch, but it is easily fatigable. But the type 1 is the slow twitch muscles, but this is fatigue resistance. Now, this is twitch, slow twitch muscle. What do you mean by? What do you mean by that? Means the contraction and relaxation process. That means the simple muscle twitch will be slow. Slow means what will happen to the time duration? Time duration will be prolonged. And this white muscle is type 2, that is the first twitch, means contraction and relaxation both will be rapid. So, if I give this graph and rather than asking this question, if I ask you which one is the type 1 muscle and which one is the type 2 muscle, your easy answer will be type A. Okay, sorry, graph A is the fast twitch muscle, that is the type 2 muscle, and graph B is the slow twitch muscle, that is the type 1 muscle. First, you have to understand this. Right. Second thing, the question here is asking what is the cause of this latent period. Getting my point? What is the cause of this latent period? So, if I give a stimulus at the level of neuron, right, the action potential is traveling down the neuron, then it is crossing the neuromuscular junction, then it is stimulating the muscle. So, latent period का cause is ये जो neuron से travel हो रहा है, then it is crossing the neuromuscular junction, all this will come into the latent period. Okay, but even if I give a direct stimulus on this muscle membrane, direct stimulus on muscle rather than giving stimulus to neuron, even if I give direct stimulus on the muscle membrane, then also muscle will contract, but again there will be a latent period. And that is the question they are asking here, कि if you give a depolarizing stimulus directly on the muscle, although it is not given, but the question is related to that you have given a stimulus directly on the muscle membrane. Muscle will contract, but it will take some time. Why? Question is, if I give a stimulus on the muscle, that is the electrical activity. How the electrical activity leads to contraction of the muscle? You have to understand. Electrical activity leads to contraction of the muscles by releasing calcium. Now, in which organelle calcium is stored? Sarcoplasmic reticulum. So if you think of a skeletal muscle, you know that if this is a skeletal muscle membrane, all of you know that there will be a T tubules on the muscle membrane. So this pink color line that I have drawn here, this is a sarcolemma, muscle membrane, okay, and there will be presence of a sarcoplasmic reticulum. All of you know this. Now the channels which are present on this T tubule membrane, this channel is known as the DHPR receptor. डाइहाइड्रोपाइरिडिन रिसेप्टर, सब लोग जानते हैं आप लोग. दिस इज द कैल्शियम चैनल, ओके. DHPR, डाइहाइड्रोपाइरिडिन रिसेप्टर, दिस इज अ काइंड ऑफ वोल्टेज गेटेड कैल्शियम चैनल, इसीलिए इसको लिखा जाता है CAV. CA stands for calcium, V stands for voltage gated, CAV 1.1. This is the recent naming of DHPR channel, CAV 1.1, right? You have to remember it, okay, you have to remember it. And the channel which is present on this sarcoplasmic reticulum membrane, this is RYR, ryanodine receptor channel, but in skeletal muscle the subtype of the ryanodine receptor which is present is RYR1. Okay. Now if I generate an action potential on this muscle membrane, what will happen? There will be depolarization of this muscle membrane. There will be depolarization of this muscle membrane, right? This depolarization, positive sign, depolarization, RMP change हो गया, that is depolarization. This depolarization will activate this DHPR channel. After the activation of the DHPR channel, look at, concentrate, this DHPR channel will change its conformation, and one part of the DHPR channel is going to interact with this RYR channel. So this is basically simple. This is basically DHPR and RYR. Whenever the DHPR channel is activated, how it will be activated? By depolarization. Whenever it is activated, the protein of the DHPR channel will change its conformation, and because of the conformation change, it is going to interact with the RYR, and then it will cause twisting of the RYR. Now whenever the RYR is twisted because of the DHPR interaction, it will open up, and through this open RYR channel, calcium will be released from sarcoplasmic reticulum, and this calcium will causes contraction, right. So as you can find out here that even if I generate an action potential on the muscle membrane, it is taking some time. Why time? Because this DHPR and RYR, they are interacting with one another, This is known as DHPR RYR coupling, DHPR, okay, RYR coupling बोला जाता है. This is known as DHPR RYR coupling. This coupling will take some time, and then the calcium will release, and then the contraction is going to happen. So obviously you require some time. So basically if I go back to this question, the answer of this question will be C, option number C, that calcium to accumulate in the sarcoplasm. This is the answer of this question. Am I clear right now? Okay. Am I clear? Tetanic stimuli coming. Hold on, tetanic is coming, right. So first of all you tell me whether you understood this or not. So this phenomena where the DHPR and RYR is interacting with one another, what type of interaction this is? See, DHPR and RYR, they are coupled, but this coupling is happening through physical interaction, mechanical interaction. And when these two receptors are mechanically interacting with one another in presence of electrical activity, in presence of action potential, that's why this coupling is known as electromechanical coupling, okay. Electromechanical coupling. Why electro word is used? Because in absence of electrical activity, the coupling between DHPR RYR is not going to happen. That's why the complete name is electromechanical coupling. समझ में आया? So in case of skeletal muscle contraction, 100% calcium कहाँ से आता है? Sarcoplasmic reticulum. So 100% source of calcium is sarcoplasmic reticulum. ठीक है. And the coupling between DHPR and RYR is electromechanical coupling. Always choose electromechanical word if it is given in the options. Otherwise mechanical coupling is okay, but without electrical activity mechanical coupling cannot happens, right. But you have to understand one step ahead here, because this is typical of skeletal muscle. In case of cardiac muscles, this mechanism is a little bit different, okay. So that difference you have to make out, otherwise you will not be able to answer in your MCQ. So suppose this is cardiac muscles. In cardiac muscle, similar kind of diagram is seen, Okay, there will be T tubules, and obviously just opposite to this T tubules the sarcoplasmic reticulum will be there, and it is said that the distance between these two T tubules and sarcoplasmic reticulum is very very less, only 15 nanometer gap होता है इनके बीच में. इसलिए whenever there is change in conformation there will be interaction. But the thing is that in case of cardiac muscle, the DHPR channel is different in nature. Okay, although the name is DHPR, but in case of skeletal muscle I told you what is the name, CAV 1.1. In case of cardiac muscle this is CAV 1.2. See, so why 1.1 and 1.2? Why I am giving different name although both of them are DHPR, dihydropyridine receptor, because the property of these two channels are different in skeletal muscle, in cardiac muscle. So in cardiac muscle this is CAV 1.2, right? And the RYR channel which is present on this sarcoplasmic reticulum, this is also different, this is RYR type 2, right? So ये जो RYR ryanodine receptor skeletal muscle में type 1, cardiac muscle में type 2, smooth muscle में type 3, इसका 3 वेराइटी होता है राइनोडिन रिसेप्टर का, राइट? सो स्केलेटल मसल 1, कार्डियक मसल 2, स्मूथ मसल 3. एंड ये जो कैल्शियम चैनल का जिसका हम लोग बात कर रहे हैं, सो ये जो CAV 1.1 ये कहाँ पे होता है? स्केलेटल मसल में होता है. CAV 1.2 ये कहाँ पे होता है? ये कार्डियक मसल में भी होता है एंड ये स्मूथ मसल में भी. दिस इज ऑल्सो प्रेजेंट इन द स्मूथ मसल, कार्डियक एंड स्मूथ मसल इन बोथ CAV 1.2. Am I clear? Okay, all this thing you have to remember, believe me. Okay, these are the recent thing you have to remember, right? Okay, अब देखो. So if I produce a action potential directly on cardiac muscles, again the same thing is going to happen. There will be depolarization of the membrane. Listen carefully. But whenever there is depolarization of the DHPR in cardiac muscle, so this DHPR is different, CAV 1.2. If you activate this CAV 1.2, the channel will open up. The channel will open up. This is one of the major difference. In case of skeletal muscle, DHPR, although it's a channel, but it was not opening up. Here it is opening up because it's a separate subvariety. So whenever the DHPR channel is opening up, it's a calcium channel. So calcium has to enter through this channel. So where from this calcium is coming? ECF calcium, that is the blood calcium is coming. No mechanical interaction यहाँ पे नहीं होता है. Okay, देखो ना. So outside calcium, ECF calcium, blood calcium is entering in the cell. In skeletal muscle we have not seen this. In skeletal muscle blood calcium was not entering the cell for contraction, only sarcoplasmic. That's why I told you 100% source of calcium. In case of cardiac muscle, outside calcium will enter the cell, but this calcium which is entering from ECF, amount is less. Amount is less means it cannot produce full contraction of the cardiac muscles. So it has to take help of sarcoplasmic reticulum. But how it will take help? See, the RYR type 2 channel which is present in the cardiac muscle, this channel property is again different from the skeletal muscle. This is known as calcium gated calcium channel. This is known as calcium gated calcium channel. What is the meaning? Calcium gated calcium channel means the gate of the channel will open in presence of calcium. That's why the name of the channel is calcium gated calcium channel. ठीक है. So whenever the extracellular calcium is entering in the cell, this calcium is a stimulus for RYR channel opening, gate opening, and whenever it is stimulating the opening of the RYR gate, the sarcoplasmic reticulum calcium will also enter the cytoplasm, and then the combination of these two calcium will causes contraction. Getting my point? So in these cases, the outside calcium which is coming from ECF, this is responsible for 20% and the sarcoplasmic reticulum calcium is responsible for 80%. So if the question is like this, yeah, indirect action of digital is not here, that is the transporter, that is a blocker of the sodium potassium ATPase pump. Okay, right, look at here. So what I say, in cardiac muscle, suppose the question is like this, what is the major source of calcium? Your answer is sarcoplasmic reticulum. But if the question is what is the essential source of calcium? Essential means if you remove that calcium, cardiac muscle contraction will stop. Then your answer will be ECF calcium, blood calcium. Because if this ECF calcium is not entering, then the RYR channel will also not open up. Cardiac muscle contraction stop हो जाएगा. The scientist has proven this in experiment that in heart, if your extracellular solution does not contain, okay, If it does not contain the calcium, then cardiac muscle stop, contraction will stop. So blood calcium 0 हो जाएगा तो cardiac muscle contraction will also stop. Getting my point? So these two things, and here the DHPR and RYR coupling. Is it a mechanical coupling? Are you any mechanical interaction, physical interaction between these two receptor? Answer is no. There is no physical interaction, but who is interacting? Who is communicating between these two channels? Calcium. Calcium is a chemical substances. That's why this is known as electrochemical coupling. This is known as electrochemical coupling in case of cardiac muscle. Okay. Electrochemical coupling sometimes is also known as CICR, calcium induced calcium release. Again I am repeating, calcium is inducing release of calcium from sarcoplasmic reticulum. That's why this outside calcium is inducing the release of sarcoplasmic reticulum. This is known as calcium induced calcium release. So electromechanical coupling is skeletal muscle, and electrochemical coupling in cardiac muscle. Electrochemical coupling is also known as CICR. Okay. So I hope this is clear. This is one of the important topic I am telling you, okay, which has already been asked and it will be asked in the future also. Okay. Chalo, we are going to the next question. So someone of you are asking the tetanic. So this is the question, okay, regarding your tetanic contraction. Okay, आगे ना अभी चलो, okay. Okay, चलो आपको ये क्वेश्चन आंसर करो. So it's a repeat question, multiple times it has been asked in, okay, AIIMS entrance examination. So here again the diagram which is given here is a simple muscle twitch. I explained what is simple muscle twitch, right? So you remember simple muscle twitch. Now second thing that they are asking here, the tetanizing frequency. So I have to first understand what is tetanization, right? Now everybody look at my board. So if this is the graph, x-axis and y-axis, okay, absolutely correct, Dr. Dreamer, your answer is correct, but look at the understanding. So if I give a stimulus, okay, so if I give a stimulus, so there will be an action potential. After this action potential, the muscle contraction and relaxation will happen. This is nothing but known as the simple muscle twitch. We have already understood this, right? Now if I give multiple stimulus, okay, suppose I have given a stimulus here, now I am giving another stimulus here. This is the first stimulus, this is the second stimulus. What will happen? The second contraction will start here and it will go like this. But look at, the height of the second contraction is much more than that of the first contraction. You may ask that why this is happening. You know, whenever you have stimulated one muscles, the calcium which has been released into the cytoplasm, okay, it will again go back to the sarcoplasmic reticulum. It will again go back to the sarcoplasmic reticulum by a transporter protein. Here there is a transporter protein which is known as the SERCA. आपको पता होगा, SERCA, sarcoplasmic endoplasmic reticulum calcium ATPase, right? But it will take some time, na? So the calcium which has already entered into the cytoplasm, it will be mopped up by the sarcoplasmic reticulum with the help of this SERCA pump. But it will take some time. By the time, if you give a second stimulus, so already some calcium is still there in the cytoplasm and you have given a second calcium. So further calcium will enter in the cytoplasm from sarcoplasmic reticulum. So available calcium will be more and that will rise the height of contraction or force of contraction. This is known as the beneficial effect. Beneficial effect. This is known as a beneficial effect. What do you mean by that? Means second contraction is getting benefited by the first contraction. That is the meaning of beneficial effect. Second contraction is getting benefited by the first contraction, that is beneficial effect, right? Okay. So if you continue this kind of stimulation rather than giving second stimulation, if I go on giving multiple stimulation like this, what will happen? There will be gradual increase in height of contraction. होगा कि नहीं होगा? So देखो, if I go on giving this multiple stimulation, so the contraction, relaxation, contraction, full relaxation, contraction, full relaxation, contraction, full relaxation, height will increase up to the fourth. But after that, no further height will increment. Means this will be like this because there is a limit, na? Sarcoplasmic reticulum में कितना calcium होगा? There is a limit. So obviously after this fourth, there will be no further increment of height. बोला जाता है कि the height of first contraction जो होगा and the maximum height will be 4 times that of the first contraction height, right? But look at, so if you look at this contraction and relaxation, I can find out that there is a step by step increment of height of contraction. this step-by-step phenomena where the increment of height is occurring, this is known as the staircase phenomena, or this is also known as TREPPE, ट्रेपी phenomena, staircase or ट्रेपी, right? staircase और ट्रेपी phenomena, समझ में आया? ओके, सो क्वेश्चन दिया जाता है staircase और ट्रेपी phenomena क्या होता है? सो बेसिक थिंग इज दैट you are giving multiple stimulation, but multiple stimulation is coming after the full relaxation, of the muscle. But suppose you are giving multiple stimulation, but the relaxation is not complete. Relaxation is not complete. लिखो. So contraction, relaxation is going on, but relaxation is not complete. Before that, you have given the second stimulation. So here is the first contraction stimulus. This is the second stimulus. So now the second contraction will start from here. Again, it is going to relax, but before that, you have given the third stimulus. Again, it is going up like this. So what is the difference between this and the staircase or trapeze? The difference is that in staircase or trapeze, every contraction is getting fully relaxed, and then I am giving the next stimulus. But here I am not allowing the muscle to relax completely, incomplete relaxation. So this is known as incomplete tetanus generation, incomplete tetanus generation. So tetanus का meaning होता है sustained contraction. Here there is sustained contraction, but there is partial relaxation in between. Getting my point? This is incomplete tetanus. So whenever I am saying incomplete tetanus, if I say complete tetanus, what will happen to the diagram? Complete tetanus means you will give no relaxation time. So whenever one contraction is going on, it is just about to relax, but before starting of relaxation, I have given the second stimulus here, means all this contraction will fuse up with one another. So whenever it is trying to relax, I have given the third stimulus. So means all the contraction are getting fused with one another without any relaxation in between. This is known as complete tetanus generation, and this complete tetanus generation requires a high frequency stimulus. Why high frequency stimulus? Because you have to give multiple stimulus, and all these stimuli should fall in the period of contraction. Getting my point? Here incomplete tetanus means the stimulus is falling in the period of relaxation. Okay. In trapeze also the stimulus is falling after relaxation, but in complete tetanus each stimulus is falling in the period of contraction, means I have given second stimulus within the period of the first contraction, third stimulus within the period of the second contraction, fourth stimulus within the period of the third contraction, right. So the basic bottom line is that if you want to produce a complete tetanus, your stimulus frequency should be so high that each of the stimulus should fall within the period of contraction. Means in this simple muscle twitch, if I want to produce a complete tetanus, I have to give a first stimulus here, second stimulus must be within the period of contraction. That is why the formula for calculating tetanizing frequency is 1 upon contraction period duration. What is mean once? 1 means 1 second, 1 second means 1000 millisecond upon your contraction period duration in millisecond. So my basic bottom line, which I have to understand from here, sorry for the disturbance. So I have to understand from here is in this simple muscle twitch, you find out what is the period of contraction, what is the duration of contraction. Okay, and you can find out here that it is starting almost from 0 and the contraction is up to this level. So if I drop a perpendicular from here, the duration of the contraction period is 40 millisecond. So if I divide this 1000 millisecond, right, upon this 40 millisecond, that is the contraction period duration. So this will be 25 Hertz, and that's why the answer here is 25 Hertz. So everybody tell me whether you got it or not. So Meghal Gaur, I know what is your confusion, adaptation and accommodation. Question is coming. Hold on. Okay, question is coming. But you have understood this or not? Okay. So contraction period duration you have to find out. You have to divide 1 second period upon the contraction period duration. Whatever is the frequency, all this frequency, all these stimuli will fall within the period of contraction. Correct? Okay. Chalo. Got it. Okay. So अभी से गलत नहीं होगा ना? Promise? अभी से ये क्वेश्चन को गलत नहीं करना है. दिस इज़ अ वेरी easy question, you know, easy question, but your understanding should be this, whatever I discussed here. Okay. Now next question. So this is a repeat question as per I remember. So tell me the answer of this question. Read the question. The answer is within the stem of the question. Even if you don't understand the image, the answer is within the stem of the question. Okay. So थोड़ा सा पानी पी लेता हूँ. चलो. So electron micrograph of human gastrocnemius muscle, right? So titin, a little different answer. So what I can find out here, that this is basically something which is attached on this Z line. बहुत बढ़िया, I am very good. Okay. So little bit ups and down, but overall I am good. Okay. Concentrate on the question. So look at here. This is a molecule. If you look at the description, protein mark in A is in the Z disc. Following diagram helps in binding of actin to Z line. Okay, titin is a protein which is extended from one part to other part, but it's not a binding protein for actin. The answer here is a alpha actinin. So look at, for quick understanding, I have made this diagram. So you can find out that this is the diagram of the sarcomere. All of you know the bands, डार्क बैंड, लाइट बैंड, ये सब अभी डिस्कस करने का टाइम नहीं है, राइट. आई होप ऑल ऑफ यू नो दैट द मायोसिन इज द डार्क, ओके, ए बैंड, ओके, फॉरगेट अबाउट दैट. सो दिस इज माई जेड लाइन, राइट, दिस इज माई जेड लाइन. So the distance between two Z line is the sarcomere, okay, and this white color structure is the myosin, right. Wow. So this white color structure is the myosin, and this pink color structure that you are finding out, this is actin. So this pink color, this is actin. इसका जो लेंथ होता है 1 माइक्रोमीटर के आसपास होता है, 1 माइक्रोमीटर होता है इसका लेंथ, राइट. एंड ये जो मायोसिन का लेंथ होता है, दिस इज 1.6 माइक्रोमीटर इज द लेंथ ऑफ दिस, ओके. सो हियर ऑल्सो दिस इज 1.6 माइक्रोमीटर, एंड हियर ऑल्सो दिस इज 1 माइक्रोमीटर. फॉरगेट अबाउट द लेंथ, इवन इफ यू डोंट रिमेंबर, नो प्रॉब्लम. बट लुक एट few molecules I have to remember for MCQ. What is that? At the middle of the myosin, there is a little elevated region. There is a little elevated region like this. This elevated region, okay, when it touches with one another, why touches? Because this is the diagram of only one sarcomere, but there will be thousands of sarcomere which will be packed inside the muscles. So whenever one myosin is touching with another myosin, the center of the myosin, there is a little elevated area, and this elevated area will touches with one another, and it will gives the appearance of a line which is known as the M line. M line, right. So M coming from a German word Mitchell-Scape बोल के होता है, forget about that. So M line से लेके Z line तक, from this M line up to the level of Z line, there is a elastic molecule connected. This molecule is known as titin. This molecule is known as titin. Getting my point? So what I have to remember about titin? Very very important information. T-I-T-I-N, titin. टाइटन ही नहीं, ठीक है ना. सो टाइटिन इज अ इलास्टिक मॉलिक्यूल. आपको क्वेश्चन दिया था नीट पीजी में, दैट इलास्टिसिटी ऑफ द कार्डियक मसल ड्यू टू व्हिच प्रोटीन. योर आंसर इज टाइटिन. whether it is skeletal muscle or cardiac muscle, elasticity, if you stretch the muscle will relax a little bit. This is elasticity. Elasticity is due to this titin. So it is an elastic protein, okay, connected from M to Z line. This is the typical description of the titin protein, and it is said that titin protein, the molecular weight is very very huge, one of the largest protein in human cell. It contains around 25,000 amino acid. Okay, so this is one of the largest protein in human cell, elastic protein, M to Z line protein. Now see, the function of this titin is that it holds myosin, at the center of sarcomere, okay. Okay, see, myosin always we draw at the center of sarcomere, but we have not think of that how the myosin is there at the center of sarcomere, why it is not moving here and there. What is the attachment with this myosin and Z line? There must be some attachment, na? And that attachment is done by titin. So titin is fixing the myosin at the center of sarcomere by connecting the M to Z line, right. The third information that you have to remember, that if there is a mutation of this protein, okay, could you tell me what disease is going to happen? What disease is going to happen? In case of heart, if this protein is mutated, titin protein, then hypertrophic and dilated cardiomyopathy. So, you remember cardiomyopathies, right. Myopathies, hypertrophic and dilated cardiomyopathies ka one of the cause is mutation of this titin protein. And second, if there is mutation of this titin in skeletal muscle, there will be myopathy, but typically the myopathies that has been found out is the tibialis muscles myopathies. Tibialis muscles myopathies has already been found out. So, tibialis myopathies and cardiomyopathy, particularly hypertrophic and dilated cardiomyopathy, you have to remember. Very good, right. Okay. So, this is first protein, titin. Second, the actin remain attached with Z line with the help of a protein. This protein is known as alpha actinin protein. Alpha actinin protein, or it is also known as CAP Z protein. So, in this question, this alpha actinin is there. Even if the actinin is not there, suppose cap Z is also there, then is also going to be your answer. So, this alpha actinin or cap Z, it is a Z line protein. It is present only on the Z line, and the function of this protein is to attach the actin with the Z line, right. So, this is cap Z. Now, actin molecule, you know that actin molecule, I told you what is the length, 1 micrometer. Now, there is a possibility that the length of the actin myosin may decrease or increase. So, who prevent the change in length of the actin myosin? You have to remember there is a molecule which is connected from this Z line up to the tip of the actin molecule, and this molecule is known as the nebulin molecule. This is known as the nebulin molecule. So, nebulin, from where to where it is connected? Look at, again I am drawing. So, from the tip of the actin, it is connected up to the level of Z line. It is not a elastic protein, although I am making like elastic protein, but it is not a elastic protein. It is known as a fencing protein, barrier protein surrounding the actin. Means actin ke char pas mein it will form a barrier, so that it will prevent the loss of length of actin, right. So, it is known as nebulin. So, this protein is known as nebulin. We said the nebulin is attached from tip of actin to Z line, tip of actin to Z line, and what is the function? Regulation of length of actin molecule, regulation of length of actin molecule, right. So, ये हो गया nebulin protein. I hope you understood. So, titin, nebulin, myosin, baki you know, okay. So, nebulin protein is attached from the tip of the actin up to the level of Z line. If there is mutation of this nebulin protein, then again there will be a myopathy. The name of this myopathy is known as Nemalin myopathies. Nemalin myopathies, right. So, the Nemalin myopathies can affect any of the muscles in the body. It can be congenital also, it can affect the childhood also. There will be weakness of the muscles, and this disease is known as Nemalin myopathies, right. Fine. So, these are the basic information that you have to remember for this information. Now, आगे बढ़ते हैं, okay. So, this is the next question, try to answer. Look at this question, try to answer. So, the figure here, as you can find out here, the motor neuron, and motor neuron is connected with the trying, okay, chalo. So, in this question you can find out a motor neuron, and motor neuron is connected with an inhibitory interneuron. You know, the name of this inhibitory interneuron is nothing but Rensa cell. Rensa cell, and Rensa cell is a typical example of negative feedback inhibition. Very good, okay. So, basic diagram that has been given in this diagram is that if this is a motor neuron, okay. So, motor neuron is supplying the skeletal muscle, okay. There will be a branching from this motor neuron, okay. This branch is going to act on an inhibitory interneuron, and this inhibitory interneuron is inhibiting the same motor neuron. ये जो white color cell, this is known as Rensa cell. Rensa cell inhibition is a negative feedback inhibition. It is also known as recurrent inhibition. recurrent inhibition. ये नाम याद रखो. Okay. Yes, cerebellum में feed forward mechanism is there. The Purkinje cell inhibition is an example of feed forward. So this is negative feedback or Rensa cell inhibition. And second question that can be asked, what is the neurotransmitter of this Rensa cell? Obviously inhibitory neurotransmitter, but here the neurotransmitter is glycine, right? This much of information you should remember here. Okay. So this is typical of Rensa cell inhibition ka diagram. Chalo. Now this is a little bit difficult question. Okay. Let's see how you answer. The receptive field, okay. So I can find out that there is a large receptive field here and there is a smallest receptive field here. Okay. So among these 4 diagram, I can find out that this is the smallest receptive field. Okay. Very good, my dear. Very good, Dr. Manika. Excellent. So this question you have to answer based on your concept that which touch receptor, which mechanoreceptor which are present on your fingertips has the smallest receptive field, and the answer is directly to Merkel's, right. So that is why the answer of this question is Merkel's. The smallest receptive field is Merkel's. Now I hope all of you know what is the meaning of receptive field. Receptive field means that area of the receptor from where if you give a stimulus, the stimulus will be perceived in the brain, right. So if the receptor field is large, then if I give a stimulus here, if I give a stimulus here, both will be perceived by the brain. But if the receptor field is small, then if I give a stimulus here, it is not going to perceive by the brain. But if I give a stimulus here, that is going to be perceived by the brain, right. That is the meaning of receptive field. That from where the reception is happening, that is the receptive field. Okay. अब देखो ये जो FA1, FA2, SA1 and SA2, what is the meaning of that? FA stands for fast adapting receptor. Fast adapting, maybe you have already read, that is known as a rapidly adapting receptor, and SA stands for slow adapting receptor. Now आप आंसर बताओ कि रैपिडली अडेप्टिंग रिसेप्टर क्या क्या होता है हमारा बॉडी में. रैपिडली अडेप्टिंग टच रिसेप्टर क्या क्या है. So rapidly adapting receptor is the Pacinian and Meissner's, right. These two are the rapidly adapting receptor. Now rapidly adapting receptor is RA or FA, fast adapting receptor, right. But FA1 होगा कि 2 होगा, whether it will be FA1 or FA2, that 1 or 2 is determined by the receptive field. If the receptive field is smallest, then it will be 1. If the receptive field is large, then it will be 2. So ये दोनों में से Pacinian and Meissner's में से if you look at, then Pacinian corpuscles has larger receptive field and Meissner's has small. So इसलिए Meissner's is known as FA, okay, 1, and Pacinian is FA, fast adapting or rapidly adapting receptor 2. Similarly, slow adapting receptor हमारा body में जो main slow adapting receptor, that is the Merkel's, okay, Merkel's and Ruffini's, right, and Ruffini's. Similarly, Merkel's has the smallest receptor field, so that's why this is SA1, and Ruffini's has the largest receptor field in comparison to Merkel's, so that's why this is SA2. समझ में आ गया. So ये जो SA1, SA2 सा नाम दिया, this is just to make you confuse, simple, just to make you confuse, otherwise there is no meaning of this, right. So in this question, only information that I have to remember is the smallest receptive field touch receptor is the Merkel's. Please note down, smallest receptive field touch receptor is the Merkel's, right. Because of this property that Merkel's has the smallest receptor field, this is the best receptor for 2-point discrimination. Are you getting? Right. So if I give 2 point on this receptor, suppose there is a gap of 2 millimeter between this touch. So this is one touch, this is another touch point. There is a gap of 2 millimeter and it is falling on the same receptive field of a single receptor. The brain will perceive them as a single touch. Brain is not going to differentiate. But if I give a stimulus here and if I give a stimulus here, okay, one touch is here and another touch is here. So these two touch are falling on two different receptor field. Brain will perceive them as separate. Brain will perceive them as two touch. So this is nothing but your 2-point discrimination property, and this is best perceived by which receptor? Merkel's. So please note down 2-point discrimination. 2-point discrimination is best done by Merkels. Am I clear? Because of the same reason, the reading of Braille, there is a confusing area. The Braille reading is also best done by Merkels. So B-R-A-I-L-L-E, Braille. What you know? The Braille contain dot like this, okay, in different direction, right? Okay, different direction, right? So first you have to perceive this dot as a separate one. The best receptor for perceiving the dot point is the Merkels. So that's why the best receptor for reading Braille is Merkels. But rather than perceiving the dot, you also have to understand that whether the dots are in the horizontal direction or in the vertical direction. That means you have to move your finger on this dot. Blind person has to move your finger on this dot, and they have to perceive whether these dots are in horizontal or vertical direction. What is the direction? So whenever you are moving your finger, moving touch is best detected by Meissner's. That's why I also require Meissner's, but without Merkels, Braille cannot be read because the dots, the elevated point, you cannot perceive. So if I have to answer only one, that what is the best receptor for reading Braille, here I have taken this from the Candel's principle of neuroscience, where clearly it is written that Merkel cell is the best receptor for reading Braille. ठीक है, इतना सा ध्यान रखो, your answer will be done. Hi. Okay, now next question is here. Okay, look at here. Look at here. Question is diagram C. So what is this diagram? Which receptor this is? So first of all, you have to understand that in this diagram, what is this and what is this? So stimulus is given and the action potential is also given. Stimulus and action potential both are given. So look at the explanation. Okay, look at the explanation. So suppose I am giving a stimulus like this. Okay, what is the meaning of this diagram? If I say that this is my stimulus, what is the meaning of this? Means suppose I am giving a touch on your skin. Touch means there will be an indentation of the skin. So if I give a touch here, there will be indentation of the skin. Suppose I am measuring how much indentation is happening, maybe 1 millimeter, 2 millimeter, 3 millimeter. So I am raising this indentation. I am giving more and more touch, right? Whenever I am giving more and more touch, if I record the action potential from neuron of the receptor, right, what will happen? The action potential will appear like this. So this single जो line है ना, this single lines are action potential. ये जो depolarization and repolarization, this is a single line denoted here as a single line, right? So this single line is the action potential. Okay, then you look at, then if I keep this indentation for long duration, I am holding this touch for long duration. I say like this, that when you holding your holding the hand of your girlfriend or boyfriend for the first time, you holding the hand of your girlfriend or boyfriend for the first time, you will feel the touch, and that's a very electrical kind of sensation. But if you hold the same hand for 1 hour, do you feel the same touch? Answer is no. Why? Because although the touch is still there, but the receptor is modified, receptor is adapted. And why the brain is not perceiving the touch? Because brain can understand only the action potential. If I hold the stimulus for long duration, so this is sustained touch for long duration, what will happen? The action potential will disappear gradually. And whenever the action potential are disappearing gradually, then you are not going to perceive the sensation. This is the typical understanding of which phenomena? Adaptation phenomena. Getting my point? This is the typical example of adaptation phenomena. So what is adaptation? If you keep a sustained touch for long duration, the action potential is disappearing, vanishing, right? and that's why you are not perceiving the sensation, that is known as adaptation. So adaptation is occurring at the level of receptor. Receptor is modifying in a way, your action potential is not coming, right. So if the action potential is continuously coming in the same manner, then what I will say, the receptor has been adapted or not adapted? Adapted or not adapted? Receptor is not adapting, that's why the action potential is coming and coming in, getting my point. So if the receptor is continuously coming up, then receptor adaptation is not happening. So this is typical of slow adapting receptor diagram. This is typical of slow adapting receptor diagram. And if the action potential are disappearing quickly, if the action potential are disappearing quickly like this, then the receptor is getting adapted quickly, then that will be the example of rapidly adapting receptor. So now if I go back to this diagram, okay, so in the x axis I can find out this is stimulus, this is stimulus, this is stimulus, this is stimulus. Same kind of stimulus is given all 4 types of receptor, are you understanding? But if I count the number of action potential, here I can find out 1, 2, 3 action potential, and then there is no action potential for a long time, means this is adapted. If I count here 1, 2, 3, 4, 5 and then adaptation. So here 5 then adaptation, here 3 then adaptation. So which one is the more rapidly adapting receptor, C or A? What will be your answer? Which is the most rapidly adapting in this receptor in this diagram? You just count the action potential number, okay. If it is disappearing quickly, then that is a rapidly adapting receptor. So I can find out here that diagram C, okay, diagram C is a rapidly adapting receptor, diagram A is also a rapidly adapting receptor, and here in D action potential is not disappearing, it is continuously coming, it is continuously coming, means it's a slow adapting receptor. Maybe it will adapt maybe later on, but here I am not getting adaptation. Adaptation होगा तो action potential आएगा नहीं, right? So if I have to differentiate between C and A, which one is the most rapidly adapting receptor? Your answer is C. You know, most rapidly adapting touch receptor in our body is Pacinian corpuscles. That's why the answer here is Pacinian. Are you understanding? Okay, are you understanding? So that's why C is the most rapidly adapting receptor, and C is what we know from our information that yes, B and D, this is also slow adapting, this is also slow adapting, B and D are slow adapting, very good, right? So this is the answer, Pacinian corpuscles. I'm getting, are you getting, right? So here 2 things you have to understand. One is the adaptation, just now we have discussed. Why C more? That's why I was explaining that count the number of action potential. Okay, in both the cases action potential are disappearing, but before disappearance of the action potential, how much action potential the receptor has generated? Here only 1, 2, उसके बाद ही disappear करना शुरू कर गया, means बहुत ही rapid adapting, भाई, right? And here it is disappearing, but before that it has generated few action potential, so little bit slower adapting than that of the C. Okay, that's why C is the most rapidly adapting receptor. Pacinian receptor is best for vibration. The best stimulus for Pacinian is the vibration. That question has been asked already. Okay, so now we look at, so adaptation phenomena is if you continue a stimulus for long duration, that stimulus should be suprathreshold. Okay, yes, A will be the answer. So if you keep a suprathreshold stimulus for long duration, right, then receptor will be modified, and because of the modification of the receptor, you are not going to perceive the sensation. This is known as adaptation phenomena, right? Adaptation phenomena. But accommodation means, देखो what is written, refer to a gradual increasing stimulus, refer to a gradual increase in threshold caused by prolonged slow rising subthreshold stimulus. Very important. If you are stimulating a neuron, you are giving the stimulation in a slow manner, धीरे धीरे stimulation देते जा रहा हूँ, तो what the neuron will do? Neuron will be very angry. Why you are doing like this? You give me a sudden stimulus, I will generate action potential, but you are giving me slow stimulus for long duration. ऐसे क्यों कर रहा हूँ? Neuron will be very angry, and whenever neuron is angry, it will raise its threshold. Okay, so you are giving stimulus, neuron is supposed to generate action potential, but now the neuron is very angry because you are giving slowly rising stimulus, धीरे धीरे stimulation दे रहा हूँ, so neuron will raise its threshold. अब करके दिखाओ, neuron बोलेगा now you do, I am not going to generate action potential because my threshold is raised. This is the phenomena which is known as accommodation phenomena. This is the phenomena which is known as accommodation phenomena. Getting my point, right? So this accommodation and adaptation is very important for your MCQ. Please try to understand, right? Okay. Chalo, next question. So next question here, in the following diagram, which best illustrate the state of a person who receive 1 liter of drinking water? 1 liter of drinking water. Which of the following is the best? So this diagram which has been given here, okay, this is dy diagram. This is known as Darrow-Yanet diagram. Darrow-Yanet diagram, dy diagram. Okay. So now here, so dy diagram, look at this diagram first. X axis is the volume axis, this is also volume axis, and y axis is the osmolality axis, right. Now in this diagram you are finding out this white color box, so this is the volume, total volume of water which is present in your body. So this white box indicates this is the total volume of water which is present in the body. We know the total body water has been divided into 2 parts. One is the ECF which has volume of 1/3. So this is the ECF volume and this is the ICF volume which is 2/3 of the total volume, 2/3 of the total body water. ठीक है? So left side indicate कर रहा है ICF volume, right side indicate कर रहा है ECF volume. In steady state condition, both ECF and ICF has same osmolality. Equilibrium is maintained, same osmolality. Now in this picture, if you give a isotonic saline solution, suppose 0.9% NaCl infusion you have given, 0.9% NaCl solution you have given. So you are giving this infusion to blood. Directly the fluid is going into your blood, means your ECF volume will increase. So ECF volume increase means this box will look like this. This box will look like this. There is increment of ECF volume. But will there be any change in osmolality of the ECF? Answer is no, because this is a kind of isotonic fluid. Same, ठीक है? समझ में आ गया? Okay. So if you give ECF solution to a person, only the ECF volume will increase. There will be no change in osmolality of the body fluid. But if you give hypotonic solution, suppose you are giving hypotonic solution to a person. Hypotonic means ये जो ड्रिंकिंग वाटर होता है ना, ये जितना भी मिनरल वाटर हो जाए, इसमें इतना मिनरल, इतना सॉल्ट नहीं होता है कि इट्स आइसोटोनिक. सो इट्स हाइपोटोनिक ऑलवेज. Suppose I am taking this hypotonic water, so it will be absorbed from my GIT. After absorption, it will reach to the blood. Means again there will be increase in ECF volume first. Okay. So ECF volume increase means it will increase like this direction. But tell me, if you ingest a hypotonic solution, what will happen to the tonicity or osmolality of your ECF? Hypotonic solution you have injected, so what will happen? There will be decrease in tonicity of the ECF, means this diagram, this ECF, now it will look like this. So look at this pink color box. Look at this pink color box. So what is the meaning of this box? This means the osmolality of this new ECF is lesser than that of the original ECF, and the volume of the ECF has been increased. So volume has been increased in this direction and osmolality has been decreased. But this is not a steady state condition, you know, this is not a steady state condition. It cannot remain like this. Whenever the tonicity of the ICF is higher than ECF tonicity, ICF tonicity is higher than ECF in this condition, what will happen? There will be osmosis. Osmosis means water will move from low solute concentration to high solute concentration. So this is the movement of water. Whenever the ECF is hypotonic, now the water will move from ECF to ICF. Only water. Whenever water is moving into the ICF, what will happen to the volume of the ICF? The ICF volume start increasing like this. ICF volume will start increasing, and this increment will continue until and unless a new equilibrium developed. So now the ICF will looks like this. So what is happening? If you are taking a hypotonic water, there is increment of volume of the ECF also, there is increment of volume of the ICF also, and there is decrease in the tonicity of the ICF also, there is decrease in the tonicity of the ECF also. यही तो meaning हो गया. Now after understanding this, if you look at this question, okay, अब क्या answer होगा? What will be the answer? Okay, so here only you have to look at solid line represent the original condition, okay, and dash line indicate the final steady state. So I can understand that here this is the dash line, this is the dash line, and this is the solid line. So obviously the answer is going to be C. No, not B. B is means solid and broken line mein you have confused. Okay? Otherwise look at solid line indicates steady state condition. So steady state condition is this, and then the new condition will look like this, new condition will look like this, right. So this is best here in C. Okay? So that's why the answer is C here. Okay? So this is the new condition, this is the original condition. Okay, chalo, next question. So next question is here, very easy question, very easy question. Answer. I am absolutely sorry for the disturbing noise in between. सर्दी जुकाम होके बैठा है. Which curve describe the alanine profile along the nephron? Alanine profile along the nephron. So what is alanine? It's an amino acid. What we know? We know that amino acids and glucose, they have similar kind of property. All of them will be completely absorbed at the level of PCT. At the level of PCT, 100% reabsorption will occur. So if you look at this curve, y-axis is the percentage of filter load remaining in the nephron. Percentage of filter load remaining in the nephron. You first have to look at the y-axis very carefully. So during filtration, suppose during filtration the load is 100%, right. Suppose the load is 100% amino acid or glucose. We know that from proximal convoluted tubules 100% is going to be reabsorbed. So what will happen to the luminal concentration or percentage of filter load? It will be near equal to 0. So that's why if we follow this curve A, B, C, okay, A and B, both of them are completely reabsorbed in the nephron. यही तो meaning A and B दोनों में ही देखो. In both the cases, the concentration, the percentage of filtrate load is getting near to 0. A is completely 0 and B is near equal to 0. So this B curve is probably most of the cases it may be sodium or it may be potassium, because we know in case of sodium 99.9% is reabsorbed. So this B curve is probably sodium and this A curve is typical of glucose or amino acid. So obviously the answer of this question is curve A. So this C curve indicate that whatever is the amount of filtration here, 100% filtration, there is no change in the amount throughout the nephron. What is the substances? This is typical of inulin. This is typical of inulin because it is neither reabsorbed neither secreted in the nephron. Am I clear? What is D? That we will discuss in the next question. So the same kind of curve is given, but here the question is para-amino hippuric acid. Okay, inulin. Yes, absolutely inulin. Very good. Very good. So already answer हम लोग बोल ही दिया. So same curve. Okay. So what I am showing the same question because you know the same curve can be given for a different question. Here para-amino hippuric acid, we know that it's a freely filterable substances, right, as well as it's a substances which is hugely secreted at the level of PCT, hugely secreted at the level of PCT. So secretion means there will be increase in concentration. So D, answer here is the D. Am I clear? Am I clear? So these two, I think this is clear, very simple question. Okay. So this is the diagram I have taken from Genome. Okay. Here you can find out the different substances, the discussion that we are doing here. Okay. You can find out the same thing here. See, this is creatinine. What is the property of creatinine? It is like that of the PAH, but PAH secretion is very, very high. Creatinine secretion is very less. So that's why this curve is above the inulin curve. So this is the inulin curve, right? Okay, and this is the glucose curve. You can find out here proximal convoluted tube में खत्म हो गया, and the sodium curve is getting near equal to 100% reabsorption, but at the end of the nephron. Okay, so that's why this curve is important to understand. Okay, next question is here: at which nephron site is the tubular fluid upon plasma osmolality is lowest in a person who has deprived of water? A little difficult question. Okay. Yeah, curve for glucose and amino acid is same. Both of them are reabsorb 100% in the nephron. Proximal tubule में absorb हो जाता है 100%, right? So now in this question, what do you mean by this tubular fluid upon plasma concentration? What do you mean by this? You know, the tubular fluid upon plasma concentration, if I say that this is 1, indicating the osmolality of the tubular fluid is equal to plasma osmolality, means this is what kind of solution? Isotonic urine. Tubular fluid tonicity is same with the plasma tonicity, that's why the ratio is 1. What is the meaning of this? Means the tubular fluid is isotonic to plasma. If the tubular fluid upon plasma concentration is greater than 1, then tubular fluid is hypertonic in nature. Getting my point? And obviously, if the tubular fluid upon plasma tonicity is less than 1, then this is a hypotonic. Getting my point? Okay. Now the question is saying that the person is deprived of water. Why this statement is given? When the person is deprived of water for some times, there will be increase in osmolality. There will be increase in osmolality. Increased osmolality is a stimulus for secretion of one hormone, that is ADH. That is ADH, right? Now, with this concept, we are going to discuss this question. So, we know from our basic knowledge that if this is the Bowman's capsule, proximal tubule, then this is the nephron, loop of Henle, and then this is the DCT, and this is the collecting duct. This is a schematic diagram of nephron. What you know? What kind of fluid is present at the level of proximal convoluted tubules? It is isotonic. Isotonic. Screen is cleared, check your network. Okay, thank you for helping. So, PCT is isotonic. Isotonic means what will happen? TF upon P will be equal to 1, right? Then you know that when the fluid is going through this loop of Henle, water will be reabsorbed, but solute is not going to be reabsorbed. That's why at the tip of loop of Henle, the solution will be hypertonic, right? Then when it is going through the ascending part of the loop of Henle, all of you know that solute is going to be reabsorbed here. So, when the solute is reabsorbed, then what will happen to the tonicity of the tubular fluid? First it will be isotonic, followed by it will be hypotonic, means at the level of DCT, the tonicity of the fluid will be hypotonic, right? Now, this hypotonic solution which is present in the DCT, okay, this will move through this collecting duct, and जितना सारा खेल है ना ये collecting duct पे है. Why? Because the actions of ADH, where the ADH reabsorb water, it reabsorb water at the level of collecting duct mainly, although later part of the DCT is also there, but mainly collecting duct. So, up to the level of DCT, ADH has no direct action, means ये जो isotonic, hypertonic, hypotonic, this will happen whether the ADH is there or not. But if the ADH is present, then it is going to reabsorb huge amount of water when the ADH is positive. So, if it is reabsorbing water from a hypotonic solution which is flowing through the collecting duct, ultimately the urine which is going to release from here, that will be hypertonic again, right? Means in presence of ADH, answer my question, in presence of ADH, maximum tonicity of urine or tubular fluid is at which level? At the level of collecting duct, and minimum tonicity कहाँ पे होगा? At the level of DCT. Getting my point? DCT. That is in presence of ADH. So, this pink color writing that I have drawn here, this is in presence of ADH. But if the ADH is absent, then water reabsorption here is not going to happen. There will be very little percentage, 2% आसपास. So, the hypotonic solution which was flowing through this collecting duct, you are not able to reabsorb water from this hypotonic solution, or you can say you are reabsorbing solute continuously even at the level of collecting duct, but you are not reabsorbing water adequately. So, what will happen? The final tonicity of the urine will be further hypotonic. DCT में जितना hypotonic था उससे भी hypotonic हो जाएगा. This is in absence of ADH negative. That means the question is in absence of ADH, okay, ADH minus. If my question is maximum tonicity of urine कहाँ पे होता है? आपका आंसर होगा लूप ऑफ हेनले का टिप में होगा, बिकॉज उसके बाद पूरा ही हाइपोटोनिक ही बनते जाएगा। गेटिंग माय पॉइंट? सो ये जो टिप ऑफ लूप ऑफ हेनले में हाइपरटोनिक हुआ था, इसके बाद द यूरिन विल बी मोर एंड मोर हाइपोटोनिक because ADH is not there. If the ADH is not there, collecting duct is not going to reabsorb adequate amount of water in respect to solute. But if the question is in absence of ADH, the minimum tonicity will be where? Then your collecting duct end. See, same question. I am asking maximum minimum tonicity, but just depending on this ADH, the question answer is different, right? So if the ADH is absent, then urine will be very, very hypotonic at the end of this collecting duct. And if the ADH is present, urine will be very, very hypertonic at the end of the collecting duct, right? So in this question, they are asking that the person is deprived of water. So ADH concentration is very high. ADH concentration is very high mean lowest tonicity कहाँ पे होगा? Lowest tonicity कहाँ पे होगा? So देखो, ADH is present. Lowest tonicity कहाँ पे? Lowest tonicity कहाँ पे लिखा है? ADH is present. Lowest tonicity कहाँ पे? DCT. So in this diagram, which one is DCT? Side number D. So that's why the answer here is side number D, right? Thank you so much. चलो, are you understanding? Okay. Now ये question का answer हो गया, I think. Now look at the next question. Next question is similar. Next, very good, DCT, right? Now next question is similar. At which nephron site does the amount of potassium in the tubular fluid exceed the amount of filtered potassium in a person on a high potassium diet? A difficult question. High potassium diet. CR में भी सेम होगा ना, SI या DH में भी सेम होगा ना, because उसमें ADH secretion is inappropriately high due to some tumors, you know. So that's why the same in presence of ADH वाला scenario होगा. And if you ask me diabetes insipidus में क्या होगा, तो ADH absent वाला scenario होगा, ठीक है, right? Shubhasis, I hope you understood. Okay, now here you look at when a person is taking high potassium diet. आप जानते हो पोटासियम सिक्रेशन कहाँ पे होता है? पोटासियम इज द ओनली इलेक्ट्रोलाइट, मार्क माई वर्ड, पोटासियम इज द ओनली इलेक्ट्रोलाइट which is reabsorbed as well as secreted in the nephron. और ऐसे कोई भी इलेक्ट्रोलाइट नहीं है जिसका एब्जॉर्प्शन सिक्रेशन दोनों ही होता है. सोडियम का सिर्फ सिक्रेशन होता है, क्लोराइड का भी सेम, बट यहाँ पे सिक्रेशन भी होता है एंड एब्जॉर्प्शन भी होता है. नाउ सिक्रेशन ऑफ पोटासियम ऑकर्स हियर. This is the site where secretion of potassium occurs, right? Means DCT, mainly the ending part of the DCT is the most important site जहाँ पे potassium secretion होता है. Although there is a little secretion of potassium at the level of collecting duct. So DCT and collecting duct में potassium secretion होता है, ठीक है. बाकी जगह पे मीन्स ये प्रॉक्सिमल ट्यूबुल में एब्जॉर्प्शन होता है, इस जगह पे भी एब्जॉर्प्शन होगा, बट सिक्रेशन ऑफ पोटासियम ऑकर्स एट द लेवल ऑफ DCT, the ending part of the DCT, which is known as the connecting tubules as well as collecting duct. Remember. Okay, now when the person is taking high potassium diet, body will try to get rid of potassium. Not required to land here. Okay, when you are taking high potassium diet means your blood contain huge amount of potassium, the body will try to get rid of potassium. How to get rid? You have to secrete more potassium. So where from the secretion will happen? The secretion is going to happen here. So if the secretion is happening in this zone, then maximum potassium concentration will be in which part of the nephron? That's why the answer here is D, right? Getting my point? All of you are getting my point or not, right? Okay, so secretion of potassium is happening here, that's why secretion maximum concentration is E. Okay, now ये जो नंबर मैंने यहाँ पे लिख के रखा, यहाँ पे देखो, when your potassium is low in the diet, in condition में when you are taking less amount of potassium in your day to day diet, then body will not try to secrete potassium. Obviously your blood potassium is less, body is not going to secrete potassium, but here reabsorption. So everywhere the potassium is getting reabsorbed when your body potassium is less, right? Now when your potassium is high in the diet, now the body has to get rid of potassium. Now where the body is secreting potassium, in which part of the nephron? So this is the area where the secretion of potassium is happening. And look at the percentage of potassium secretion. The secretion amount can be 180% also. 180% means suppose your filtered amount of potassium is 100%, secretion can be even more that of the filtrate amount. So, if I ask a question that a person who is high in potassium diet, the major source of urinary potassium, is filtration or secretion? कहाँ से ज़्यादा पोटेशियम आ रहा है आपका यूरिन में? The person who is high in potassium diet, the major source of urine potassium is coming from filtration or secretion. What is your answer? Secretion can be more than that of the filtration. So, that is why it is coming from the process of secretion, and that has been asked here in this question. So, answer here is E. समझ में आ गया? I hope this is clear to all of you. Okay, चलो next question. Okay, so next question is, this is a repeat question in NEET. I hope all of you know the answer of this question. All of you will answer. I am 100% sure. Okay, so yes, so this is basically your Laplace law. Okay, law of Laplace. Okay, law of Laplace is saying yes that P is equal to twice T by R. Okay, so T is the tension. Whenever more and more urine is entering in your bladder, okay, the tension at the level of this wall, will increase, and proportionally there will be expansion of this bladder. So, radius will also increase. So, basically the bladder tension is also rising, radius is also rising in a ratio, both if denominator and numerator both are rising proportionally, then P will remain constant. So, that is why ये जो part, this part is the application of the Laplace law. उसके बाद क्या होगा? उसके बाद there will be sudden appearance of the micturition reflex. Whenever your bladder urine volume is more than 400, okay, now your micturition reflex will start, and whenever micturition reflex start, sudden increase in intravesicular pressure will be there, and that is shown here in this curve. Okay, so this is simple. Answer is 1B, Laplace law. Okay, chalo. Next question. Okay, so little difficult question, but I will say that this question can be given without this image also. Only one information you have to take from this image is this transport maximum, that is 300, that you have to take from this image. Okay, otherwise this question can be given without the image also. So, this image is explaining that reabsorption of the glucose is happening, then there is a plateau of reabsorption, means glucose reabsorptions occurred by SGLT. So, there is a limitation that how much glucose can be absorbed by SGLT transporter. Whenever there is saturation, no further increment of glucose absorption is possible, and that point where all the SGLT are saturated, that point is known as the transport maximum of glucose. Okay, so now this question ko dekho, 55-year-old overweight patient, estimated GFR is estimated GFR is 150 and glucose is 400 milligram per dl. Very good. Okay, so look at, so if this is the afferent arteriole, this is the glomerular capillary, it is said that the glucose concentration is 400 milligram per dl. So, first of all I will convert this into 4 milligram per ml. DL is the 100 ml. So, I am converting the blood glucose into ml, right. It indicates that 1 ml of plasma contains 4 milligram of glucose, and in 1 minute what is the GFR? GFR is 150 ml is the GFR in 1 minute. So, I can understand that 1 ml of plasma contains 4 milligram of glucose. If there is filtration of 150 ml of plasma, how much glucose will be entering in the Bowman's capsule? That is 4 multiplied by 150. Getting my point? Means if I multiply the blood glucose multiplied by GFR, then you are going to get a amount, that how much amount of glucose is going to be filtered here. This is known as the tubular load or filter load of glucose. Filter load or tubular load of glucose. Very good, very good. Okay, so filter load of glucose here is 4 into 150, that is 600 milligram. Within this 600 milligram, the transport maximum T max is given. How much? That is 300 milligram per minute. Means within this 600 milligram of glucose which has reached here, within this 600 you are maximum, you can absorb maximum how much glucose? 300 milligram. So if you absorb 300 milligram of glucose from here, the remaining glucose that will appear in the urine is 300, right? So that's why the answer of this question is D, that is the 300 milligram. ठीक है, समझ में आ गया? I hope this is clear. Okay, चलो. Okay, sorry, here. Next question. In a scientific research, okay, what you are finding out that large number of subject has been followed, okay, and you are finding out that the systolic BP is rising and diastolic BP is falling, okay. Systolic BP is rising and diastolic BP is falling, ठीक है. So this typically happen after a age of 60 or more, and that is due to increased stiffness of the arterial wall. Increased stiffness of the arterial wall. Whenever your arterial wall is stiff, your systolic blood pressure will rise up, okay. So it is said that increased stiffness of the arterial wall means there is decreased compliance of arterial wall, decreased compliance. So whenever there is decreased compliance or increased stiffness of the artery, systolic blood pressure will rise and diastolic blood pressure will fall, right. So that has been asked in this question. The detailed discussion is not possible in this session, it will be there in the lecture, okay. अभी के लिए इतना ही ध्यान रखो, okay. चलो, now next, cardiac response to moderate supine exercise in normal human and a patient with a transplanted heart are recorded. Okay. So now here you look at the curve. One curve is from normal person, one is from transplanted person, right. The mark difference that you can find out here, that the heart rate is rising gradually in transplanted person, okay. But in case of normal person, the heart rate is rising very rapidly, okay. So you know that in case of normal person, heart rate increases immediately after starting of exercise, sometimes even before the starting of exercise. What is the reasons for this increased heart rate in normal person? This is due to sympathetic stimulation. What I told? After you start the exercise, sometimes even before the starting of exercise, heart rate increment can also occur even before the starting of exercise, and this is due to psychic stimulation. Psychic stimulation means you are just thinking that I have to start the exercise, okay, and this thinking will increase your heart rate, that is known as psychic stimulation, okay. So sympathetic stimulation will be activated, but before that psychic stimulation will increase the heart rate. But a person with a transplanted heart, okay, the sympathetic parasympathetic system has already been cut, right, and you have transplanted the heart to a different person. Sympathetic parasympathetic re-innervation is not possible. So in this transplanted heart patient, heart rate will increase. Answer is it should not increase because sympathetic parasympathetic is not there, but still the heart rate can be increased because of epinephrine and norepinephrine. What will happen? When the transplanted heart person is doing exercise, there will be stimulation of the sympathetic system. Look at this, sympathetic system is not going to affect the heart directly, no, but this sympathetic system will stimulate the adrenal medulla, and this adrenal medulla will secrete epinephrine and norepinephrine. That epinephrine and norepinephrine is going to act on the beta-1 receptor which is present on the heart cell membrane. Sympathetic parasympathetic is not there, but membrane to intact na, and membrane mein jo receptor beta-1 that is also intact. So this epinephrine and norepinephrine will act on this beta-1 receptor, and then the heart rate will start increasing. That's why in case of transplanted subject, heart rate will rise, but not immediately. Immediately nervous system से ही possible है. Later on heart rate will increase, and that later on increment of heart rate is due to epinephrine and norepinephrine which is secreted from adrenal medulla. ठीक है, so please remember this thing. ठीक है, so इसलिए ये जो question है कि the slow rise of heart rate in a transplanted person is due to circulating catecholamines from adrenal medulla. ठीक है, please note down. Okay. So few information you have to remember, that in case of transplanted heart person, how the cardiac output is rising, heart rate rising slowly, but cardiac output कैसे rise होगा? It is said that mainly because of the Frank-Starling law, cardiac output increases even in transplanted heart person also. Cardiac output increases even in transplanted heart person also due to Frank-Starling law. Okay. Okay, I will tell you. So three things you remember: increase in end diastolic volume will increase the length of the heart muscles, that will increase the contractility of the heart. Okay. This is known as the Frank-Starling law. Okay. Increase in heart rate can also increases the contractility of the heart. This is known as BOWDITCH, Bowditch effect. Increase in afterload means aortic pressure can also increases the contractility of the heart. This is your ANREP effect. So remember these three effects. Okay. So increase length, increasing the contractility. Okay, thank you so much. So this is increase in contractility. Increase heart rate can also rise the contractility, that is Bowditch effect. Increase in afterload can also increase the contractility, that is ANREP effect. Okay. So I think this is clear to all of you, this question, transplanted heart wala question. So please remember that sympathetic innervation, re-innervation is not possible, but it is the catecholamines which increases the heart rate slowly. Okay, chalo. So ये जो point, this point we have already discussed, that what happens in case of transplanted heart. You can read it later on also. Okay. Now look at here. Next question. So here you have to remember certain important information, that first heart sound correspond with R wave in the ECG. So this heart sound is corresponding with the R wave. This is my first heart sound. So this B is the first heart sound, right? Then second heart sound occurs at the beginning of the relaxation of the heart, at the beginning of the relaxation of the heart. Relaxation means after the repolarization of the heart. So first there will be repolarization, then there will be relaxation of the heart, or diastole of the heart will happen. So whenever there is diastole, the second heart sound will happen, and repolarization होने के बाद diastole start होगा. After repolarization, diastole will start. Repolarization in the ECG is denoted by T wave. So at the end of the T wave, the heart sound which is appearing, that is the second heart sound. So this C is second heart sound, right? Second heart sound. Then how to understand the third and fourth heart sound? Remember that the fourth heart sound correspond with the atrium contraction. Atrium contraction. ठीक है. Fourth heart sound correspond with the atrium contraction. Tell me, atrium contraction means you require atrium depolarization. Atrium depolarization in the ECG is denoted by which wave? Atrial depolarization in the ECG is denoted by P wave. So if a heart sound is corresponding with the P wave or appearing just after the P wave, then that is the fourth heart sound. So this is the fourth heart sound. In between the heart sound that you are getting here, this is the third heart sound. So D here is the third heart sound. So obviously if the question is asking second heart sound, your answer is point number C. Okay. Okay. So I think we can do or one or two questions, and then we have to end the session at 7 o'clock. Okay. So let's see. Okay. SR correspond with the R wave. S1 correspond with the R wave peak, R wave peaking, right. Now this diagram, have you seen this diagram? This is the aortic pressure curve. Okay. Look at, I am drawing the diagram, try to understand. Suppose this is the left ventricle, this is the arch of aorta, okay. This is the arch of aorta. If there is ejection of a stroke volume, right, if there is ejection of a stroke volume, what will happen? There will be increase in aortic pressure, there will be increase in aortic pressure, right? So, this pressure rise, if I plotted on a curve, what will happen? Okay. So, if I plotted on a curve, it will look like this, okay. So, this is happening during ejection of the blood. After that, what will happen? At the end part of the ejection, the aortic pressure will start fall down like this, Suddenly, there will be closure of the semilunar valves. After the closure of the semilunar valve, listen most carefully. After the closure of the semilunar valves, what will happen? The aorta, which was expanded due to ejection of the blood, the aorta was expanded. Now, this aorta will recoil back. So, your valves are closed, your aorta is recoiling back. So, what will happen? It will put some pressure at the level of this blood. So, there will be increase in aortic pressure once again. So, that is why whenever there is a closure of this semilunar valves, after the closure there will be little increase in aortic pressure once again, and then the aortic pressure will falls to a very low level like this. समझ में आया? So, ये जो point, this green color point, this is the closure of the semilunar valves. So, this is my second heart sound point. After the closure of the semilunar valves, the positive wave that you have received here, this is due to elastic recoiling of the aorta. This is known as the dicrotic wave. Okay. So, this dicrotic wave is due to elastic recoiling of the aorta, and the dicrotic wave is appearing just after the closure of this second valves, semilunar valves, second heart sound. So, the point where this valves is closed, there is a notch. This notch is known as the dicrotic notch. So, after the notch, the wave is appearing. Notch is corresponding with the second valve, second heart sound, the closure of the semilunar valves. After the notch, you are getting a wave, that is a dicrotic wave. And the wave which is created by this ejection of the stroke volume, this wave which is happening during ejection of the blood, this is known as the percussion wave in aortic pressure. Percussion wave in aortic pressure. समझ में आ गया? So, if you record the pressure from the aorta, you are getting a maximum pressure point. So, this is the aortic pressure. Yeah. The reflection wave sometimes a tidal wave में आता है, and if you go towards the periphery, this wave character will change. Okay, that is due to increased stiffness and increased reflection, right? But at the level of aorta, we are discussing here. So, at the level of aorta, the maximum pressure that you are getting here during ejection, this is known as the systolic blood pressure, because this pressure will be transmitted throughout your blood vessels. So, the maximum pressure that you are getting in the aortic pressure curve is the systolic blood pressure, and the minimum pressure जहाँ पे आके ये flat हो रहा है, this is the diastolic blood pressure. Okay, maximum pressure point is the systolic blood pressure and lowest point is the diastolic blood pressure, and the difference between this systolic and diastolic blood pressure is obviously the pulse pressure. The pulse pressure we know. Now you tell me, baroreceptor is most sensitive to which pressure? Note down, baroreceptor is most sensitive to pulse pressure followed by mean arterial pressure. I am not saying, this is completely written in Genong. Okay. So, baroreceptor is most sensitive to pulse pressure. So, in this diagram, at which point pulse pressure is maximum? If I measure pulse pressure continuously, so I can easily understand the pulse pressure is the difference between systolic and diastolic blood pressure. So, this is maximum here. उसके बाद pulse pressure is gradually reducing. So, if I have to answer that baroreceptor will be activated, baroreceptor firing, what do you mean by baroreceptor firing? Baroreceptor firing means action potential generation of baroreceptor stimulation, that is firing, activation. Firing means activation. So, baroreceptor activation is maximum at which point? The point where the systolic blood pressure, that is the point number A. Answer. Okay? If you do not believe me, obviously you are believing, but if you do not believe me, look at this diagram which is taken from Genong. So, this single line, this single line, this kind of line we have already seen in receptor adaptation. This line indicate these are nothing but action potential. More the action potential means more the activation of baroreceptor. More action potential means more activation of baroreceptor. So, if I think that the pressure, blood pressure is 75 millimeter of mercury, blood pressure is 75 millimeter of mercury. At this 75 millimeter of mercury, in which point you are getting maximum firing of baroreceptor? At this point. At this point. What is this point? This point is corresponding with the highest pulse pressure points. Again, whenever the pulse pressure is rising, then you are getting some action potential. Again, you are getting action potential here. That means if you look at this diagram carefully, you will find out more the pulse pressure, more is the number of action potential in baroreceptor. Okay. So, that means maximum baroreceptor firing will happen when the pulse pressure is the highest, and highest pulse pressure is appearing in which point? This point. Am I clear? Am I clear? Okay. Chalo. Okay, next MCQ. Next MCQ here. So, same question, PV loop, PV loop, PV loop. Okay. So, whenever the questions is coming about the PV loop, okay, you know ki PV loop, you have to understand ki which phase indicate what, right. So, this PV loop from D to A, percussion versus tidal wave is a little different. Tidal wave जो tidal wave always मिलते नहीं है, जो ये जो descending part हो रहा है ना, here ये जो descending part, इस जगह पे sometimes और एक थोड़ा सा positive wave मिल सकता है, which is due to reflection of the pressure wave from the arterial tree. That is sometimes known as the tidal wave. Okay, but most of the cases it is not seen. Okay, great. Okay, chalo. So, now if you look at this PV loop, okay, so from this D to A, this is the filling of ventricle, ventricular filling is going on, and then there will be isovolumic contraction. So, from this B to A is the isovolumic contraction, and then from D to C this is the ejection, and then from this C to D this is the relaxation. Basically in bottom line the PV loop. In cardiac cycle different phases has been described here. So, if you look at this question here, isovolumic contraction they are asking. Isovolumic contraction means volume is same but pressure will rise inside the ventricle. So, that is typically this A to B, where the volume is same but the ventricular pressure is rising gradually. So, this A to B is the isovolumic contraction part, okay, and ये जो C to D, this is the isovolumic relaxation part, isovolumic relaxation. ठीक है, ये very simple. I hope all of you know the PV loop, right? Now, second question is also on PV loop, okay, but here they are asking the first heart sound or second heart sound? First heart sound they are asking. First heart sound. So, you know कि first heart sound mean whenever there is onset of ventricular contraction. Whenever there is onset of ventricular contraction, that will give you the first heart sound. Okay. So, onset of ventricular contraction means yes. So, point number B is the answer here. So, option A is the answer, point number B is the first heart sound. So, I am writing here this is the first heart sound and this D is the second heart sound. This D is the second heart sound. ठीक है? Okay. Great. Chalo. So, now some of the MCQs of respiratory system. These are the MCQs which I am not going to discuss in detail, okay, because it will take some time, maybe in other session if it is possible later on. But look at the question. Compliance. So, only information I have to remember here is high compliance, okay, high compliance, you have to remember emphysema and little bit in case of asthma, okay, and low compliance, okay, all of you know this, low compliance is mainly fibrosis or any case of restrictive lung disease, okay. So, obviously answer here is A, because as you can find out here, this A indicate high compliance curve rather than normal. Okay, high compliance curve. Not all COPD, okay, because bronchitis may, in bronchitis compliance is absolutely normal. In bronchitis compliance is absolutely normal. Compliance is only high in case of emphysema and little bit high in case of asthma. Okay, not bronchitis. Bronchitis compliance is almost normal. Okay. Okay. Second question. Okay. So look at the question. Static expiratory PV loop is given in a healthy person with severe emphysema. Already we have discussed, but here the question is different. Question they are asking you to calculate the compliance of this person. Okay. So look at how to calculate. Okay. Quickly. Okay. So yeah. So this is normal person. So in normal person, first you look at this exponential part of the curve. First you note down this exponential part of the curve. Okay. And then on this exponential curve you take 2 points. 1 point I am taking here, 1 point I am taking here. Look at what I am doing. Okay. What I am doing, I have taken 2 point, blue color point ko dekho. At which part of the curve I am taking? I am taking this point, one is here, another is here. आपको पता चल जाएगा why I am taking here. Okay. So these 2 points should fall on the exponential part of the curve. Exponential part of the curve here. Okay. Now you drop on perpendicular from this 5 and drop on perpendicular from 3. Okay. Now you have to extend this perpendicular line on x axis and from here on x axis. कुछ नहीं किया, perpendicular drop कर दिया. Okay. Now if I take a difference between 5 and 3, this is the volume change of the lung. This volume change is due to this pressure change P1 minus P2. So if I change this pressure P1 to P2, then volume is increasing from 3 liter to 5 liter. Means this 3 liter to 5 liter, this is change in volume delta V, and this P1 to P2, this is delta P. Compliance formula is delta V upon delta P. Compliance formula is delta V upon delta P. So delta V here is the volume change, 3 liter to 5 liter means 2 liter, and pressure change if you measure, so this is around 10 centimeter of water. 10 centimeter of water, right. So 2 liter means 2000 ml per 10 centimeter of water. So obviously this is 200 ml per centimeter of water. This way you have to calculate the compliance if the given in like this, right. So in this question the answer here is C. समझ में आ रहा है? Okay, how to calculate the compliance curve? Okay, चलो देखते हैं और कुछ क्वेश्चन है कि नहीं. Obviously there will be some question. So now you look at this question. 2 questions I will show. Same type of curve will be there. Okay, but don't think that this is the oxygen hemoglobin dissociation curve. Not, it may be difference also. So in one question, first question here, suppose this is MCQ number 1 and another MCQ here, this is MCQ number 2. Okay. So in MCQ number 1, y axis is oxygen saturation. In case of anemic person, oxygen saturation decreases or it remain normal. क्या आंसर वही इस क्वेश्चन में पूछा गया है. So always remember, anemic person means hemoglobin is reduced, but that does not mean saturation will reduce. Saturation SaO2 depends on partial pressure of oxygen in the blood. In case of anemia, partial pressure of oxygen in the arterial blood is normal. Arterial blood I am talking about, right? So saturation of the oxygen will also be normal. Hemoglobin saturation normal होता है. So please note down, in case of anemic person, saturation is not change. So that's why answer of this question is point number D. So this is the saturation, 100% saturation like that of the normal person. But if the y-axis rather than saturation, if the y-axis is oxygen content, look at the question number 2. Here the y-axis is oxygen content. arterial blood, how much oxygen it's contain, amount of oxygen in the arterial blood, that is the oxygen content. भैया if your hemoglobin is less, तो saturation कुछ भी normal हो जाए, hemoglobin is less ना, so how much is the total oxygen in the arterial blood? Obviously the content of oxygen in the arterial blood will also reduce. That's why this E point will denote that this is the anemic person, right? So that's why please note down, if it is saturation then it will be normal like that of the normal person, 100% saturation. 100 नहीं होता, 97 के आसपास, but anyway that is like here 100% almost. But if it is anemic person and if the y axis is oxygen content, then obviously it is going to be reduced because hemoglobin is less. Yeah. What is the doubt, sir? Compliance is inverse of elasticity. Compliance is inverse of elasticity, right? So when the outer is hard, it will not be able to expand. If it is not able to expand, it will not be able to recoil. That's why the elastic recoiling force will also decrease. Although if you expand it, it will recoil with high forces. But the ejected blood will not be able to expand the outer. That's why elastic recoiling force will be less. Now here, now in this question, this is the expiratory curve. Look at, please note down. So this is the starting point of expiration, point number A, okay. Then this is the mid part and this C मान लो point, this is the ending point of expiration. So during expiration the maximum air that you expire is known as the forced vital capacity, and within 1 second, ये जो 1 second point को देखो, within 1 second the volume that you expire, that is the FEV1. So what I have to do, I have to drop on perpendicular from this FEV1 and I have to drop on perpendicular from this FVC point. दोनों मैंने y axis के ऊपर perpendicular drop कर दिया. So मैं देख रहा हूँ यहाँ पे FVC is around 5 liter के आसपास, little more than 5 liter, and FEV1 is 4 liter के around. So FEV1 is around 4 liter or little bit more than 4 liter. But दोनों को for calculation easiness 4 liter 5 liter. So 4 upon 5 is the 80% ratio. ठीक है? I know I am going a little bit faster, but anyway, I hope you know this thing. Okay. Now coming to this question. This has been asked multiple times. I will wait for your answer. I will wait for your answer. So which hormone increases during exercise also, sleep also? Postural reflex MBBS में जरूरी होता है, for not for the NEET PG. No. So see, cortisol sleep में उतना affect नहीं होता है. ACTH and thyroid hormone, they are not affected by sleep much. Estrogen increases sleep, but sleep cannot increase estrogen. Cortisol, sleep has not much role. Insulin is same. Only the growth hormone is affected by non-REM sleep as well as hypoglycemia. Hypoglycemia होगा तो that is the strenuous exercise. So this is typical of the growth hormone. Okay. So growth hormone का जो stimulus आपको ध्यान रखना होगा, hypoglycemia, strenuous exercise and this non-REM sleep is the stimulus for growth hormone. ठीक है? Okay. Now few more questions are coming. Concentration of major ions in saliva. So this is salivary secretion. Okay. So whenever there is increase in flow of saliva, there will be increase in all ions like sodium ion, potassium ion, bicarbonate ion, all will increase. There will be only and only decrease in potassium ion. This is the only thing you have to remember. What I am saying, again I am repeating. So whenever there is increase in flow rate of saliva, there will be increase in sodium concentration, potassium concentration, bicarbonate concentration in the salivary secretion, but there will be decrease in potassium concentration. So इसका opposite होगा when the salivary flow is low. So देखो salivary flow में high flow rate means everything is high, sodium is high, sodium is high, chloride is high, okay, and bicarbonate is also high, but potassium is the lowest. And when the salivary flow rate is very, very low, then everything will be low. Sodium is low, chloride is low, bicarbonate is also low, but potassium is condition में will be highest. This is the thing that you have to remember about salivary secretion. पोटासियम एंड बाइकार्बोनेट ये डक्ट सेल से सिक्रेट होता है. पोटासियम एंड बाइकार्बोनेट सलाइवरी डक्ट से सिक्रेट होता है. ओके एंड यहाँ से हमारा सोडियम एंड क्लोराइड सिक्रेशन होता है. यू रोट पोटासियम हाई. ना when the flow is high means suppose you are taking some food particle inside your mouth, so your salivary flow will be high. When your salivary volume is high, when your salivary flow is high, potassium will be lowest and sodium chloride bicarbonate will be low. Okay. Oh, here, sorry, ये chloride, this is chloride, absolutely taken, right. ठीक है. Okay, so potassium is lowest, बाकी सब high. So देखो ये जो A, this is also rising, B is also rising, C is also rising, but D is decreasing. So this D indicate potassium. ठीक है. So this is the way how to identify salivary secretion. Now coming to the next question, or 2-3 questions are remaining, just hold on few minutes बस. So देखो ये जो क्वेश्चन दिया है, effect of various ion on membrane potential of the intestinal smooth muscles. So look at this diagram. This is depolarization and this blue color that I am drawing here, this is hyperpolarization, right. Depolarization, hyperpolarization. अब मेरे को बताओ which of the following causes hyperpolarization. Hyperpolarization means it will cause relaxation of the GI smooth muscle, and depolarization means there will be appearance of action potential. Action potential means there will be appearance of contraction. So which of the following causes relaxation? Obviously adrenaline. Getting my point? So this way you have to understand this question. Okay. So similar kind of question और एक है, आपको दिखाऊंगा, और 2 क्वेश्चन है. So this is all about the discussion that if you give adrenaline, epinephrine or sympathetic stimulation, so there will be hyperpolarization, and if you give this acetylcholine or parasympathetic stimulation, then there will be contraction. वही लिखा है यहाँ पे. Okay. Now another question, this is the question which has been asked in NEET PG. Repeat question, answer बताओ. So if you look at this question, this is the basal electrical rhythm. These are the basal electrical rhythm, BER. Okay. When the basal electrical rhythm is going above this voltage, when the BER is going above this voltage, there is appearance of the action potential. There is appearance of the action potential. Getting my point? देखो diagram को अच्छे से देखो. Whenever the BER is going above this voltage means which voltage? 50 minus 50 millivolt. That means this minus 50 millivolt is the threshold voltage. Absolutely true. So this is the true statement. Frequency of the BER is 6. देखो this 10-second time scale has been given here. 10-second time scale. Within 10 seconds I am getting only one BER. देखो. So this is BER, one BER. One BER I am getting within 10 seconds. Means within 1 minute. What is the rate of BER? Rate is 6. So this is also true statement. This is also true statement. Okay. Tension developed proportionate to the frequency of the spike potential. Absolutely true. More the frequency of the spike potential means if more action potential numbers are coming, then more contraction, more stronger contraction will happen. So this is also true, but action potential amplitude has no relation to the force of contraction. Action potential amplitude follow all or none law. Okay, इसके साथ contraction का कोई relation नहीं है. So this is my false statement and this is my answer. Okay, all of the following statement are true except कुछ है. So this is the answer. Okay, yes, 60/60. that is the 1 minute 60 second upon 10 seconds. So, that is the 6 is the BR frequency. You have to look at the x axis time scale. So, if you look at the x axis time scale, this is the x axis time scale. Okay. Now, the last question I will come to. Okay. Next last question. So, this is the last question. Okay. Again the same principle. Here the question is Dell's apparatus. What we record in Dell's Dell's apparatus? We record the movement of the GIT, movement, mechanical movement. So, contraction, relaxation of the GIT was happening, very strong contraction and relaxation was happening. Suddenly, you have given this drug X, there is decrease in contraction and relaxation. Okay. That means, GIT is getting relaxed, or you can say because of the presence of this X, there is decrease in height of contraction of the GI smooth muscle. So, again the same question, that which of these following agent causes relaxation of the GIT? Your answer is adrenaline, right. So, this is all about the today's session. I hope you got some of the information, okay. Right. So, thank you so much. Please continue. No. 2 hours was allotted to me. Okay. I have exceeded that time. Okay. You will enjoy physiology. I can assure you that. Okay. And I will also integrate physio with medicine. Don't worry. Okay. So, thank you so much for today. Okay. If you have any question, you can contact me later on. But today's session I am finishing here. Thank you so much. Bye bye. Take care.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder.